Good morning, everyone. I am all of 5 feet in height, but after Dr. Sharmishta's introduction, I feel 10 feet tall. So today it's an historical moment because we are having Teachers of Tomorrow, which has been done only twice before. And Orissa is the very first state to have this here. So a big hand for Orissa Ophthalmological Society. This is the first time it's being done in any state. Without much ado, we will go into the program. The students are going to present. They have just 4 minutes to make their presentation. Be aware of that. After 4 minutes, your presentation will stop automatically. You do not get a single spare second. So you have 4 minutes to get your message across. We have 4 judges here. However, students, do remember that you are the teacher today. The judges are your student. So don't just make a presentation, teach them. And since they are your students, do not put up with any cheekiness or any audacity from them. The judges, you are allowed 1 to 3 questions. Students, if they ask too many questions, you can always tell them to go home, study, and come back the next day. So on that note, we have the very first presentation, and she is Dr. Burla.
Good morning, everyone. As we have just passed the glaucoma week, and glaucoma is the progressive irreversible blindness in the world wide, and one of the treatment modality is YAG laser peripheral iridotomy. So this is a case of diminution of vision in the both eyes with visual acuity of 6/18, and in left eye it is 6/60. IOP is 38 mm of mercury in the right eye. In left eye it is 19 mm of mercury. Optic disc changes are normal, and on gonioscopy there is occludable angle in the right eye. So this is a case of primary angle closure, and laser peripheral iridotomy was done. So in basically laser peripheral iridotomy, we make a hole in the iris to allow aqueous to flow from the posterior to anterior chamber, relieving the pupillary block. Among the YAG laser, ND-YAG is the most commonly used nowadays, followed by combined. In 1950s, argon laser came into existence, which followed the principle of photocoagulation. But the major disadvantages being iridotomy site closure and more complications. So that led to invention of ND-YAG laser, which followed the principle of photo disruption. And the advantages of it requires low energy, and it is independent of the iris color, so easier to penetrate. Apart from the indication as we saw in the case, other indications are secondary angle closure with pupillary block, plateau iris configurations, and others as listed here. Some of the contraindications are ocular media opacity, neovascular glaucoma, angle closure glaucoma without pupillary block. Before moving to the procedure, some pre-medications to be given, that is apracolidine, brimonidine to reduce IOP, topical pilocarpine for miosis and thinning of the iris, and topical anesthesia. The site is in the superior quadrant, 11 o'clock and 1 o'clock position, which is covered by the upper eyelid. And for silicone oil, we prefer inferior iridotomy. So special contact lenses are used, that is a Weiss lens, Abraham lens with coupling agents. And the device is set at 1 to 6 millijoule and with spot size of 50 to 70 micrometer. Here you can see the arrow mark, which shows the crypt where the laser spots are given, 1 to 3 laser spots per burst. And the endpoint is the gush of pigment debris mixed with the aqueous flowing into the anterior chamber from a patent hole of size 150 to 200 micrometer. Now, these are the complications we can see post-laser, that is hyphema, corneal burns, transient rise of IOP, glare, diplopia, and late stages we may also see iridotomy site closure and cataract progression. So post-laser, we give apracolidine to reduce IOP, topical steroid to reduce inflammation. IOP should be checked regularly and routine follow-up to be done. The outcome depends on the staging, and some cases may require additional intervention. There is also significant improvement in the widening of the iridocorneal angle. It prevents acute attack in angle closure. So this is Eagle trial, which shows the clear lens extraction is superior to laser PI, but visual effectiveness is similar in cohort study. And there is one JAP trial, which shows that low incidence of primary angle closure in angle closure patients, suspect patients, which after post peripheral iridotomy. That's all. Thank you.
And our next speaker is Dr. Aishwarya Bhakta. I'm going to give you a brief review about congenital visual absence. This is a common cause of visual of the default. There are two types. Complex in complex side, we are getting data going through or the complete absence of the body clearly and the body intact. Now that the time present from the present from the consistent body without matching of fashion in this geometrical height area of the exposure. The superadded infection of the fat that into pain before related failure of the lateral of fat area known as lateral complicated stabilization. The infection of the fat can lead to formation of the lateral system. Now we need to ask about the onset frequency of the symptom, the type of symptom, whether the symptom gets active associated with that infection or not, or trauma or photophobia associated with the now, examination is performed over there is just about the activity program regarding then it means that the law of zero the level of that. Now, then the of their conflict and conflict. This conflict is photo, so the idea is abnormal lateral failure. Also, we can rule out in abnormal after primary conflict problem. Conservative management is the form of hydrostatic that we block both the common channel and place it downward and lateral. So that the hydrostatic paper is so that we open up the system block at the exit and it has to be performed so we can for at least if we become after for the 5 seconds after 18 months of age, we go for coding under the early coding is indicated to go for incorporate surgery and to or the side for patterns of protein care, so the protein or value all these things are last resort of that or by the endoscopic approach. For further information, please you can go to reference. Good morning, everyone. So, when a patient comes to our OPD with abnormal dressing of upper eyelid, that is when we say a case of congenital ptosis. Lateral is stated that simple congenital ptosis being the most common form with mean age of presentation of 2.7 years. There's a slight bit of main respondent here with violent of focus. If you already say the simple congenital ptosis is not some of the common symptoms of ptosis are these are the pictorial representations of the common symptoms of ptosis. Now, how do we see the result? The presentation of main of the physical function of unavoid resistance first, the patient may have cognitive concerns regarding this.
These are some of the complications enlisted here, out of which the important ones include post-operative lid swelling, lag of thalamus, exposure keratopathy, under-overcorrection, wound infection, etc. This is a patient where the case report of patient where patient presented with diminution of drooping of upper eyelid. Here we have done frontalis sling surgery of the patient. The take-home message is early diagnosis and timely management of a case of.
So good morning, everyone. Let's have a brief discussion on what is peripheral ulcerative keratitis. Now, a patient walks into your clinic with severe pain, photophobia, watering, redness of both the eyes. On the slit lamp examination, you find that there is a classic crescent-shaped peribulbar thinning and melting. This entity is known as peripheral ulcerative keratitis. Now, PUK, as it is known, can have both ocular and systemic causes. Among the ocular causes, they can be both infectious and non-infectious etiologies. Non-infectious ocular etiologies, namely a Murren's ulcer, rosacea, or even trauma. On the contrary, if it is a systemic cause, it can again be infectious and non-infectious. If it is non-infectious systemic cause, the most common association is rheumatoid arthritis with typical deformities of the peripheral joints, or it can be other vasculitis like a granulomatosis with polyangiitis. Remember that if it is a ocular non-infectious cause, 50% of them have an underlying collagen vascular disease. Why is it that the peripheral cornea is so susceptible to autoimmune systemic processes? It is because of certain anatomical distinctions of the peripheral cornea, namely the presence of a vascular arcade, abundance of lymphatics, Langerhans cells, IgM, and complement activating factors. The absence or presence of scleritis is extremely important in a case of PUK because scleritis indicates the presence of an active vasculitis, number one. and sometimes it prognosticates a worse outcome as well. There is an entity called Murren's ulcer, which is a type of PUK. It is a diagnosis of exclusion, but it has certain distinguishing anatomical features, namely the absence of scleritis, the presence of an overhanging edge towards the central border, and it has been classified typically as younger individuals, bilateral presentation, and a more severe or malignant course, and elderly individuals with a unilateral presentation and a less indolent course. But remember that this classification is a biased one because it has been found that 43% of elderly Murren's actually have a bilateral presentation. Reiterating another very important fact that in case of a systemic PUK, systemic vasculitis, you will find that there is a clear zone between the limbus and the infiltrate, which is classically known as the contact lens cornea because of the peripheral guttering. On the contrary, in a Murren's ulcer, it typically begins in the nasal or the temporal quadrants, and there is no clear zone between the limbus and the infiltrate. How do you approach a case of PUK? As always, take a meticulous history, including contact lens use and trauma. Always exclude any infectious causes first, because otherwise you cannot give steroids. And you have to exclude the underlying autoimmune processes by the following investigations. Management of PUK has two pillars. Number one is immunosuppression, for which you can use topical corticosteroids. Along with this, you can add cycloplegics and antibiotics. And surgical management entails mainstay being conjunctival resection and trimming of the overhanging edge. You can go for an amniotic membrane graft, or if you suspect an impending perforation, a tissue adhesive can be used. That's it.
Good morning, students. Am I audible? Today we are going to speak about optic neuritis. By end of the class, we will come to know that what is optic neuritis, what is the pathophysiology behind it, and how we are going to diagnose and treat it. So, optic neuritis is inflammation of optic nerve, which is causing dysfunction. So, first of all, under optic neuritis, we will see retrobulbar neuritis and papillitis and neuroretinitis. So, the pathophysiology being whenever there is an infection leading to blood-brain barrier dysfunction, breach in the blood-brain barrier, causing these immunomodulator cells to enter inside the central nervous system, which are damaging astrocytes and oligodendrocytes, which are responsible for the myelination, causing demyelination. So, optic neuritis will present associated with either an isolated optic neuritis or demyelinating disorder, multiple sclerosis. So, this is considered as a typical optic neuritis. Or otherwise, if it presented with acute disseminated encephalomyelitis or neuromyelitis optica, we will consider it as an atypical optic neuritis. So, the epidemiology being the prevalence rate for multiple sclerosis is 8.3 per lakh, and neuromyelitis optica being 2.6 per lakh. Then, so whenever a female patient, young female patient presents to our OPD with complaints of diminution of vision associated with pain that worsening on eye movements, and on fundoscopy showing whether normal disc or mild disc edema, that diminution of vision which is progression within hours to days, and later on it improves on its own, whether with the steroids or without steroids. We will consider it as a typical optic neuritis. So whenever either any pediatric age group or old age people present to our OPD with a diminution of vision and no pain or severe pain on ocular movements, fundoscopy showing severe disc edema, and the diminution of vision which is not improving even after 2 weeks also, even after steroids also, if it is not improving, we will consider it as an atypical optic neuritis. So what else we will see? The patients also have red desaturation and reduced contrast sensitivity. On examination in people, we will able to see an RAPD. Then in fundoscopy, we will see in retrobulbar neuritis a normal disc, and in papillitis disc edema, and in neuroretinitis, we will see retinal exudates in a stellate pattern around the macular region. Then on investigations, what else we see? We will see we will investigate the patients electrophysiologically and neuroimaging and blood and CSF analysis. Electrophysiologically, we will see in VEP there is an increased P100 latency and field visual defects. Then on blood investigations, we will see NMO antibodies and MOG antibodies and aquaporin 4 antibodies we look for. Then later on neuroimaging, we have to look for the optic nerve involvement, whether it is unilateral or bilateral involvement. Then how much segment is involved, either 3 millimeter or more than 3 millimeter. If it is an unilateral involvement with less than 3 millimeter, we will consider it as a typical one. Either bilateral involvement with more than 3 millimeter, we will consider it as an atypical one. Later on, we will do CSF analysis. In CSF analysis, we will look for oligogonal bands. Then, whenever an optic neuritis patient presents with IV steroids, we'll give. Whenever an acute optic neuritis patient presents, we'll start IV steroids. Later, CE, MRI, brain, and will be taken. So, typical, if the patient having typical findings, we will give isolated optic neuritis. 11 days of oral steroids we will give. Then in case of multiple sclerosis, we will give long-term steroid therapy. Suppose if the patients are having atypical findings, if there is an improvement in vision, we will give long-term immunomodulatory therapy, then gradual tapering of oral steroids. Suppose if there is no improvement in vision, we will give IV gamma globulins and immunosuppressant therapy. So the take-home message being, first, all the optic neuritis. Thank you.
Hello. Good morning to everyone. Myself, Abhinav Agrawal, I will be presenting our approach to anti-OPD with complaints of redness, pain, photophobia, and excessive watering from the right eye since 2 to 3 days. The visual acuity noted was 6/9 and 6/6 in right and left eye respectively. Then on slit lamp examination, there on diffuse illumination, we could appreciate upper lid edema and circumcontinental congestion in the conjunctiva. Then on slit lamp, slit beam with 1 into 1 mm with adequate intensity and magnification, we could appreciate small, fine, and medium shaped KPs and 18 to 20 inflammatory cells in the anterior chamber. And the iris details were not that clear, that were hazy. The pupil of right eye was sluggishly reacting to light compared to the left eye. On dilating the fundus, we could see the fundus to be normal. So on further history taking, there was no any evidence of similar history in the past, neither there was any systemic association. Therefore, with the presenting symptoms, that was photophobia and excessive lacrimation, and the signs that were KPs and inflammatory cells, we came to the diagnosis that is acute non-granulated anterior uveitis. So I told it to be acute because the onsets were rapid, and it was non-granulated because there was fine, small, and medium shaped KPs with more of exudation. And I told it to be anterior uveitis because there was inflammation of the anterior uveal tract. There was neither involvement of the vitreous, neither there was any history taking of every patient of uveitis is a must. It helps us in coming closer to the diagnosis. If a patient comes and complains of pain, redness, and photophobia with acute in onset, further history gives tells about arthritis, then it is suggestive of seronegative spondyloarthropathy. If history of GI or apathy also, it's suggestive of Behçet's disease. If it is post-surgical or post-traumatic, it suggests infective endophthalmitis. If the symptoms are moderate in onset with history of shortness of breath, tender over the shins, and the villous lesion, it is suggestive of sarcoidosis. If it is post-traumatic, it's suggestive of traumatic iritis, and if there is heterochromia, diffuse satellite KPs, it's fused heterochromia cyclitis. So uveitis having TB, having TB sarcoidosis, and finally take home message: a medical history and a laboratory diagnosis should be tailored in a patient with uveitis based on the anatomic features, that is anterior, intermediate, and posterior, and the clinical picture, that is granulomatous and non-granulomatous. Thank you.
Ophthalmologist, I am definitely proud of this development, starting from the Ridley's intraocular lenses of 1949 to the premium IOLs and the new generation IOLs till date. So what humans need? They need a clear vision and obviously a spectacle-free life. For that, these premium lenses are the ones which can do that function with a little bit of cost factor. So starting with a multifocal intraocular lens, and they have either refractive or diffractive based upon their optical properties. The concept of apodization is adopted so that there will be less scattering of light in the periphery, so that it increases the vision and reduces the optical aberrations in full optic. Coming on to the bifocal lenses, it concentrates on near and distant vision. There came the concept of extended depth of focus lenses, which has the main optical property of a patented diffractive plane with you the daily range of intermediate vision. Another similar lens is the Lux Smart lens of Bosch and Lomb, which is also being with the same mechanism, but unluckily it is not available in the Indian market yet. So the trifocal lenses, it is focusing with 2 diffractive properties and 2 diffractive powers, so that it also concentrates on the intermediate range. So with all these several adaptations made in these lenses, we have a better vision at near, intermediate, and distance. But these lenses also have some cons, like glare. Let's say that you have a patient of -3 diopters of astigmatism, and for that patient, the ideal treatment during the time of surgery is be very careful in selecting the biomaterial and also the good rexes, so that there will be minimal or no postoperative rotation. So students, in order to succeed in this premium intraocular lenses, you must have an extensive preoperative evaluation. There must be accurate IOL power calculation with good and recent modern formulas and an optimal surgical technique. But you should not forget that in cases of bag instead ocular surface disorders or any posterior segment pathology, it is better not to use this premium. Patient to always under promise and oversell. And don't forget to master your surgical technique so that there will be a better outcome, a better patient, and a better vision. Wait, just before I leave, let's have a small sneak peek into the future of this premium intraocular lenses, that is the light adjustable IOLs, the accommodative IOLs, and the fluid fill intraoperative IOL lenses. Thank you. I'm open for questions.
Hello everyone, good morning. Let us justify the today's topic, ocular rhinosporidiosis. Okay, from this lecture, we're going to learn about these things. Though it is not a global problem, it's been a concern of hot tropical countries of South America, Eastern Africa, India, and Sri Lanka, contributing to 88% of the caseload. Coming to India proper, the south states like Tamil Nadu, Puducherry, and Kerala are the main base, again because of hot temperatures. Other states are also involved, but rarely. Coming to Odisha, the western districts like Sundargarh, Sambalpur, and Balangir has higher prevalence compared to rest of the state. This is again because of extreme climatic conditions. Let's go through the history. Guillermo Sieber in 1900 reported the first case in a nasal polyp. At the time, it was thought to be a fish, later to be a fungus, but recently classified as an aquatic pedestal. Okay, later it was named as Rhinosporidium sieberi and classified into the class Mesomystozoa, order Damocystidium, and genus Rhinosporidium. How does it enter the body? The mode of transmission. The organism usually grows in stagnant water bodies like pond. De Mullo's theory focused on the concept of direct transmission. Like whenever the patient takes bath in pond, the organism comes in contact with mucosa and it enters the body. However, air and soil transmission is also believed. Karunaratan theory focused on the concept of satellite lesions of skin and conjunctiva, and he believes it is because of autoinoculation, just like in warts. Hematological and lymphatic spread is also observed. Whom does it affect? Young adult males are more affected. And what does it affect? Nose and nasopharynx contribute to 78% of the caseload, and 15% of the ocular involvement is seen. In this case, you can see the involvement of both. Other organs are affected, but rarely. How does a patient with ocular growth, which can be pedunculated with stroke or point spots over it, which is because, and it is too vascular that it bleeds even on touch. Structures, conjunctiva is the most common structure to be involved, and it is usually pedunculated in case of palpebral involvement and sessile in case of bulbar involvement. Rare presentations like cystic presentations are also observed. The next most common is lacrimal sac. Patient may have a boggy swelling over the sac area or even a fungating growth. The possible differential diagnoses are pyogenic granuloma, papilloma, foreign body granuloma, hemangioma, oncocytoma, or even squamous cell carcinoma. Then how do we confirm it? With the help of the other doctor, the pathologist. The definitive diagnosis is by histopathological examination. On HPE, you see different stages of maturation of sporangia, along with hyperproliferation of fibrous tissue and infiltration of the inflammatory cells. Special stains can also be used to stain the organism. Then how do we catch him? The management. Mostly it is surgical. Total excision of the growth is required. In case of lacrimal sac involvement, dacryocystectomy is usually done. However, dacryocysto-rhinostomy is also thought to give similar results by some authors. Then, how do you prevent the repeated attacks, the recurrence, which is because of spilled spores while excision? So, intraop measures like electric cauterization of the surrounding healthy tissue, as well as soakers with 5% povidone iodine after excision, and post-op measures like tablet dapsone, 100 mg given once or twice daily for a period of 3 to 6 months, also thought to decrease the chance of recurrence. But before giving dapsone, check the levels of G6PD. Okay. By the end of this lecture, the points to be remembered are: say no to.
Good morning, class. Today we'll be discussing about approach to disc edema. Many students confuse between disc edema and papilledema. So today I'll tell you, disc edema is only the swelling of the optic nerve head, while when it is accompanied with intracranial raised ICP, it is known as papilledema. These patients will come with chief complaints of nausea, vomiting, headaches, visual problems, and sometimes with diplopia. We should ask the age of the patient in these cases, the visual loss, how did it occur, whether it was sudden or gradual, painful or painless, unilateral or bilateral. Patient can have scotomas in the field of vision, and color vision can be impaired. We should ask for the history of occipitals or any other drug intake, and past history of any diabetes or hypertension or any other systemic illness. A detailed clinical examination should be done. Blood pressure should be checked for, and a systemic examination should be done. A detailed ophthalmic evaluation should be done. We should go stepwise: visual acuity, color vision, pupillary reaction, ocular motility, charting, fundus examination, and visual field should be checked for at the last. 10 signs to call it a true disc edema is 5 mechanical signs and 5 vascular signs. 5 mechanical signs is there is a loss of cup. The cup is to disc ratio cannot be assessed, and margins will be blurred. There will be nerve fiber layer edema. There will be disc elevation along with folds, Parton's line or choroidal folds. 5 vascular signs can be there. That is hyperemic disc or venous congestion or peripapillary hemorrhages, nerve fiber layer infarct, and exudates. There are many differential diagnoses. We'll discuss only a few of them today. Bilateral causes include most commonly papilledema seen in PIH or BIH. In this, there will be no RAPD, and disc edema can range from 2 to 6 diopters. Hypertensive retinopathy is also an important DD for bilateral causes. Therefore, every patient we are suspecting a disc edema, blood pressure should be checked for. Unilateral causes, papillitis is the most common confusing factor. In this, the patient can come with profound and sudden visual loss, and these patients will have a RAPD. These can have disc edema, less than 3 disc diopters, and color vision is usually impaired. These can have scotomas in the field of vision. AION, these have altitudinal field effect. These patients have a history of diabetes and hypertension. That is why in the past history, we must ask for diabetes and hypertension. CRVO is an important DD, and these have sudden and marked painful loss of vision. RAPD is usually present. Pseudopapilledema is a confusing point where this is not actually a true edema, but clinicians make a mistake by calling it a papilledema. So investigation, OCT helps to determine the amount of disc edema, and MRI, in this, if there is a papilledema, we can have empty sella or tortuosity of optic nerve, posterior sclera can be thickened. So the take-home message is bilateral disc edema is not a localizing sign, and 6/6 does not necessarily exclude retinal pathologies. We should do a fundus examination of every patient, and timely intervention to have a good prognosis.
Time up.
Treatment will be in the next class.
Should be able to answer some important questions like how does a normal epithelium heal? When you do exactly call it a persistent epithelial defect? What can be the possible etiologies and how will you diagnose and treat them? So let's start with our first question. How does a normal epithelial wound heal? It's a complex process of 4 steps, starting from a latent phase of 6 hours, followed by the basal epithelial cells migrating and then proliferating to fill the defect by 48 hours. Then they adhere to the stroma with the help of some hemidesmosomes. Remember, if you have defect in this adhesion part due to basement membrane or hemidesmosome problem, then your epithelial defect may persist. So when would you exactly call it a persistent epithelial defect? Normally, an epithelial wound should heal by 7 to 10 days. But if it fails to do so by 10 to 14 days, even with the standard therapy, then you call it a persistent epithelial defect. For this, clinically, you will have to stay in the cornea with the fluorescent dye and absorb it under the blue cobalt filter daily, noting down the defect characteristics to diagnose a PED. So once you have diagnosed it, find out why it did not heal. So it may be due to an adhesion defect as an EBMD or toxic or bullous keratopathy, or a limbal stem cell deficiency as occurs in an alkaline injury or aniridia, or an inflammatory condition leading to delayed wound healing. Also, don't forget to rule out some local or systemic damage to the trigeminal nerve or ganglia, leading to the corneal sensation loss and a neurotrophic PED. Also look for the repeated ocular surface insults and the chemical and thermal injury deep into the stroma failing to reepithelize. For this, a detailed history of the ocular and the systemic conditions like diabetes and herpetic infections and a detailed examination of the eyeball, eyelid, conjunctiva and the TBUT will help you. Also, don't forget to note down the corneal epithelial defect characteristics, vascularization, sensation, thinning, and perforation, and also the inflammation in the anterior and posterior segment to keep an eye on the complications and sequelae. Now, once you're done with the workup, how will you manage it? Your treatment should start by 7 to 10 days, with the first 10 days being very aggressive. Treat all of them, including the partially healed ones. Your approach should be stepwise, starting from a current standard treatment, which is conservative, where you treat the underlying causes, rule out the iatrogenic causes, and put the patient on aggressive lubrication. Remember, your lubricant should be preservative-free. If it fails, you can go for punctal plugs, bandage contact lens, cyanoacrylate glue, debridement, and tarsorrhaphy with tetracycline antibiotics on steroids. Always give bandage contact lenses under antibiotic cover. If it becomes refractory, you can go for autologous serum drops, blood-derived products, scleral contact lenses, including PROS. Your surgical options are amniotic membrane grafting, keratoplasty, and limbal stem cell transplantation. The novelties in development are the various topical growth factors and the trending surgery of corneal neurotization. So the take-home message of the class is always regularly examine the epithelial defect to diagnose the PEDs early. Always look for underlying causes and treat all the PEDs aggressively with 10 days.
Good morning, student. So I have a simple question for you. Can you pick out the apple for me? I mean, it's pretty easy for all of you to pick out the apple, right? But think, these all are the grayscale and two-dimensional image. Still, you have no problem in picking out the apple. But now, can you tell me which is the slide that shows ARMD? So I am here to teach you about OCT in the next 4 minutes. So OCT is a real-time cross-sectional images, and it takes cross-sectional images of living tissues like choroid. You can see this is kind of optical biopsy, and you can coherence light to produce a particular OCT. So the A scan speed was 512 scans per second, and now we have improved up to 1 lakh scans per second in case of Swepster's OCT. According to the international nomenclature for OCT, there are 18 layers, and recently added layers are myoid zone, ellipsoid zone, and interdigitation zone. So how to read an OCT? OCT should be read in a sequential manner from the inner retina up to the outer retina, and after that the choroid. Clinical applications have qualitative and quantitative implications. So these are the normal hyperreflectivity layers of retina, and also any kind of pathology in any layer of retina like hard exudate hemorrhage, they produce hyperreflectivity lesion. These are the normal hyperreflectivity layers of the retina, and intraretinal fluid and subretinal fluid, this produce hyperreflectivity lesion. So let's read some of the OCT friends. Can you tell me what is the OCT? So here you can see the posteriorly condensed vitreous had been detached from the eye limb. The contour of the fovea is well maintained and the retinal anatomy is maintained. So this is a case of, yes, you are right. This is a case of posterior vitreous detachment. Now coming to the vitreoretinal interface disorders, here the retinal anatomy is maintained, here the foveal contour is distorted. So this is a case of vitreomacular adhesion, this is a case of vitreomacular traction. Here a hyperreflective membrane over the eye limb is seen, and here there is kinking of retina. So this is a case of epiretinal membrane. Are you confused between three of the? Here you can see an epiretinal membrane that gives us a pseudo hole-like appearance, but the retinal anatomy is maintained. Here there is splitting of inner retinal layer from the outer retinal layer, and here there is no retinal layer is identified. So here this is a case of macular hole, this is lamellar hole, and this is case of full thickness macular hole. So macular edema can be presented in various of diseases. As you can see, here there is cystic fluid accumulation, hard exudates, and microaneurysm that suggests it is a case of DME. Here there is hyperreflectivity of inner retinal membrane that suggests CRAO. Here there is SRF and IRF suggestive of CRVO, and this is the case of BRVO. So there is undulation of the RP that is suggestive of dry ARMD. Here you can see subretinal fluid RPE detachment suggestive of wet ARMD, and this is a slide showing neurosensory detachment as well as pigment epithelial detachment that suggests CSR. So with the help of extended depth imaging, we can know the choroid very well, and you can see the choroid here is thickened and the outer layer of choroid, that is Haller's layer, has been distorted. So this is a case of Paki choroid. Other uses of OCT are anterior segment OCT, octa, and also for pre-perimetric and post-perimetric evaluation glaucoma to see how much of RNF layer is lost or left. We can use OCT, and recent advances are AO-OCT, EBB, home-based OCT monitoring, in-face OCT. So my take-home message is your OCT diagnosis is insufficient and incomplete without taking proper history and without proper clinical examination. Thank you.
A very good morning to one and all. Let's briefly discuss now about orbital apex syndrome. So what exactly is orbital apex? It is the most posterior part of the orbit where all the four orbital valves meet, and it is the gateway of nerve and vessels into the midcranial fossa. So what are the contents? This is the optic canal, and this is the superior orbital fissure. So the optic canal passes the optic nerve and ophthalmic artery, and the superior orbital fissure passes the cranial nerve 3, 4, V1, 6, and the superior and inferior ophthalmic vein. So when due to any medical conditions, there is involvement of both these structures, there will be occur orbital apex syndrome. So the etiology is mostly inflammatory, infectious, neoplastic, traumatic, and vascular. So what will we find in symptoms and sign? As the second nerve is involved, so visual loss will be first symptom, then followed by the other kind of symptoms like the ophthalmoplegia, diplopia, ptosis, loss of corneal sensation, perivulvar hypostasia, then relative apparent pupillary defect, and proptosis. Then how will you diagnose? Then how will you evaluate the patient? First, we have to do a correct visual acuity test, distance near color vision. Then we have to do the pupillary, see the pupillary reaction, then the ocular motility, slit lamp microscopy, fundoscopy, then both the hematological and radiological diagnosis. So always we should remember in radiological diagnosis, CT scan plays an important role in trauma and suspected magnetic foreign bodies. And for suspected vascular lesion, we should go for MRA and CT angiography. Then how will you decide for any inflammatory disease? So if there is concern for any lymphoproliferative and metastatic disease, we should do a systemic workout, CBC, CT scan, MRI. For vaginous, ANCA labels and pulmonary function test. For sarcoidosis, ACE, lysozyme chest X-ray. For thyroid, full thyroid profile. And for trauma and infection, CBC, blood culture, CT orbits and sinus. So the most two important differential diagnosis, that is cavernous sinus thrombosis and orbital cellulitis. In cavernous sinus thrombosis, what happens? The anterior segment signs are present more simultaneously, and the vision is not affected early, and the ophthalmoplegia is sequential. But in orbital apex syndrome and orbital cellulitis, mostly they are unilateral, and the differentiating factor is the visual loss is early in orbital apex syndrome and late in cellulitis. So coming to management, first we have to do observation because most cases resolve in 4 weeks. Then for medical management, for infectious causes, go for broad spectrum antibiotic, antiviral and antifungal. And for non-infectious causes, corticosteroid is the mainstay of treatment. For surgical management, we have to do orbitotomies, endoscopic decompression and tumor removal. This is the flow chart for the orbital apex syndrome assessment if V2 is involved and if not involved. Then my take home point, visual loss along with cranial of 3, 4, V1 and 6 involvement should raise the suspicion of the OS. Ophthalmoplegia is concurrent. Both hematological and radiological evaluation to be done. CT scan is more helpful than plain X-ray and MRI, and early prompt intervention results in better prognosis. Thank you. Hope you have understood something about this syndrome. Thank you.
Good morning, class. Today we'll be learning something about astigmatism under the following headings. Astigmatism is a common refractive error which accounts 13% of the refractive errors. It was first identified in 1800 by Thomas Young. It is defined as a condition where the parallel rays of light passing through the eye cannot converge at a particular point but forms a focal line. It is classified as regular astigmatism and irregular astigmatism. Regular astigmatism, the principal meridians are perpendicular to each other, and irregular, the principal meridians are not perpendicular to each other. Etiologically, corneal astigmatism will see in keratoconus where the abnormal corneal curvatures are there. Lenticular astigmatism will see in lenticonus. Positional astigmatism will see in subluxated or dislocated lens. Retinal astigmatism, the macula is placed obliquely. With the rule astigmatism, the vertical corneal meridians are steeper, and in against the rule astigmatism, the horizontal meridians are steeper. Oblique astigmatism, the two principal meridians are right angled to each other, whereas in bioblique astigmatism, they are not right angled to each other. Asthenopic symptoms, the patient will have complaints of headache, pain, heaviness in eye, transient blurring of vision, difficulty in focusing. On slit lamp examination, we have to rule out any lead abnormality. We have to look for keratoconus sign, any corneal scar is there or not, dry, any nucleus sclerotic changes, subluxation of or dislocation of lens, or whether there is any suture, this suture induced.
On dilated fundoscopy, we have to look for tilted disc and oblique placement of macula. On evaluation, we have to look for visual acuity, retinoscopy to assess the axis of astigmatism, keratometry to assess the curvature of cornea on different axes, pachymetry to know the thickness of cornea, astigmatic fan test, injection cross cylinder to identify the axis and power of astigmatism. Magnitude of astigmatism, it is classified as mild, moderate, severe, and extreme severe according to Dr. Krishna Kumar Ramani et al. On management, there will be optical correction or contact lenses like soft toric contact lenses, RGP lenses, piggyback contact lenses. On surgical management, we have toric IOL implantation, refractive procedures, and laser procedures. Toric IOLs were introduced in 19th, and it is created by incorporating a cylindrical correction on a spherical optic. Astigmatic keratotomy, it is performed by doing arcuate cuts in the mid-periphery of the cornea, which is perpendicular to the steeper axis of cornea. It corrects up to 4 to 6 diopter of astigmatism. The limbal relaxing incisions, it corrects 0.5 to 2 diopter of astigmatism. It can be performed independently or during cataract surgeries. Software guided system to reduce pre-existing astigmatism in cataract surgeries, like a superiotemporal or temporal incision is better than a superior incision, and a handheld keratoscope is used under the microscope, and Myers are repeatedly checked to minimize the pre-existing astigmatism. In take-home message, if it is treated in time, it has good prognosis. If untreated, it may lead to amblyopia. The mode of correction should be customized. Toric IOLs are effective surgical strategies for correcting astigmatism. Thank you.
A very good morning, class. Today I'll be talking on CRVO. It is defined as the occlusion of the central retinal vein at or posterior to the lamina cribrosa and is typically caused by thrombosis. We cannot proceed without paying tribute to the legend Dr. S.S. Harry, who has been a pioneer in this field. Today I'll be talking under the following headlines. Coming to the etiology, age is the most important factor, with more than 90% of the cases occurring in the older age group. Other important factors include diabetes, hypertension, ocular factors like glaucoma, ocular hypertension. Coming to pathogenesis, it lies in the anatomy, where the central retinal artery and the vein, they lie close to each other and they share a common tissue sheath. So in case of any sclerotic artery or inflammation, it leads to compression of the central retinal vein. This leads to endothelial injury, stasis of blood flow, and hypercoagulability, which constitutes the Virchow's triad. And this leads to thrombosis and subsequent development of CRVO. Coming to clinical features, it includes superficial and deep hemorrhages in all 4 quadrants, along with dilated and tortuous veins. This is typically known as blood and thunder appearance or the tomato splash appearance. Additionally, there may be optic disc edema also. OCT may show presence of macular edema. Chronically, it may present with optociliary shunts, which is a good sign of reperfusion, and sclerosed vessels. CVO study classified a CRVO into ischemic and non-ischemic types. Non-ischemic being more common. The ischemic one is defined as more than 10 dD, CN defects and visual field defects. They are more marked in the ischemic study. The conversion rate of non-ischemic to ischemic CRVO is 3.3% by 4 months. It may lead to complications such as NVI, NVA, leading to neovascular glaucoma, macular edema, etc. So coming to clinical evaluation, we should do all routine blood investigations, and if the patient is young, we can additionally go for inflammatory markers and serum examination focusing on the treatment. The management of CME is intravitreal anti-VEGF like ranibizumab, aflibercept, bevacizumab, which has been proved by evidence-based clinical trials that I have mentioned here. We can also use steroids like triamcinolone and dexamethasone. This is a pre and post injection eccentrics of left eye of a patient.
Good morning, class. So let's start about nummular keratitis. Derived from the Latin word nummulus means coin shape. These are fine granular opacities described by Dimmer as Dimmer's keratitis. Please note that this is a sign and not a disease. So the etiology may be many, but the most common and the most prevalent is adenoviral keratoconjunctivitis, which causes the most common cause of red eye, causes 50 to 70% of all cases of conjunctivitis, and is divided in 7 species and 60 serotypes. Occurs in 3 main forms, but the most important being epidemic keratoconjunctivitis. And please note, these are highly infectious. Demography. So the incubation period is roughly around 4 to 24 days, and the patient remains infectious for 2 to 3 weeks. Always take a good history about any recent eye examination, any affected family member, or any occupational exposure. So the symptoms. So like I say, as nausea, vomiting is to pharmacology, watering, redness, and photophobia is to ophthalmology. So coming to the signs, so we have lid edema, crusting, conjunctival hyperemia. We can have inferior tarsal follicles as well as pseudomembrane, which lasts for a week, which causes superficial punctate keratitis, followed by an inflammatory phase in which there is affection of the superficial stroma, causing subepithelial infiltrates in the shape of a coin. Hence the name nummular keratitis. But why do they occur? They occur mainly because of a host cell immune reaction to the virus. Because it causes increased viral replication and shedding, causes steroid dependence, and in case of misdiagnosis, we use steroids when the visual acuity is significantly deteriorated, whenever we are having subepithelial infiltration in the central cornea, or when the patient is extremely symptomatic. So which steroids to use? Well, the strongest steroid with the least side effect is usually chosen. So for mild cases, we can go for loteprednol and fluorometholone, and for severe cases, we can go for dexamethasone and prednisolone in tapering doses. Any additional treatment? Yes. We have povidone topical along with a combination of dexamethasone or any antivirals such as ganciclovir and cidofovir. However, the most important ones being immunomodulators such as cyclosporin and tacrolimus, which are used as steroid-sparing agents, decrease the occurrence of subepithelial infiltrates and reduce foreign body sensation. So prevention is always better than cure. Good hand hygiene, good use of disinfectants, use of gloves and disposable tonometer heads, and reduce contact time will really help you to prevent the chain of transmission.
Learning about ocular surface squamous neoplasia under these following headings. Von Graff was the first one to describe ocular surface squamous neoplasia as a group of related non-melanoma cancers arising within the epithelium of the and CIN3, the dysplasia of full thickness of the epithelium, whereas squamous cell carcinoma is invasion of the abnormal cells into the squamous neoplasia which include the ultra So in the management of OSSN, the surgical management is the gold standard. In surgery, we employ the Shields no-touch technique, where if the cornea is involved, we do alcohol epithelectomy with 2 to 4 millimeter free margins. If the conjunctival or limbus is involved, we do excision with 2 to 4 millimeter clear margins with cryotherapy and alcohol. And if sclera is involved, we do partial lamellar sclerectomy. So this is excision, followed by cryo, followed by amniotic membrane graft. So in medical management, we have immunotherapy with interferon alpha 2b and chemotherapy with mitomycin C and 5-fluorouracil in their respective strengths. So the indications of chemotherapy are more than 3 quadrants involvement of conjunctiva or more than 180 degrees in involvement of the limbus, clear corneal extension into the pupillary axis, positive margins after excision, and patient not fit for. So radiation therapy includes radium and strontium 90, which appears like a pterygium and has feeder vessels, and which is acquired, progressive, and fixed to tissues, should always be suspected of being a OSSN. And if there is OSSN in young patient, always.
Well, a very good morning to one and all present over here. I'm Dr. Smriti Priyadarshinikar, going to present on the topic pterygium. So coming to the introduction, it is derived from a word pteryx, which is the Greek word meaning wing. So coming to the definition, it is a triangular fibrovascular subepithelial ingrowth of degenerative subconjunctival tissue over the limbus onto the corneal surface. It usually occurs on the nasal side, but as you can see over here, it can also occur in the temporal side. Prevalence in India ranges from 9.5% to 9.5% to 13%. Etiopathogenesis. The causes can be UV rays, position, oncogenic viruses like HSV and HCV, and dysplasia. Coming to the pathology, it is an elastotic degeneration of collagen, actinic elastosis is a positive immunohistochemical staining. Then these are the symptoms of a pterygium. Mainly the problem is with cosmesis, and it can also be associated with redness, inflammation, blurring vision, and visual disturbances, mainly astigmatism. Coming to the signs, it is a fully developed pterygium in case of regressive pterygium. These are the two types, progressive and regressive pterygium. The differential diagnosis includes pseudopterygium, which can be differentiated from pterygium with the help of a probe test. Coming to the morphological grading system, which has 3 grades, T1, T2, T3. It's TAN grading system, and Cow's grading system, based on the extent of pterygium, it is also of 3 grades, 1, 2, and 3. Indications for surgery, mainly the cosmetic concern, symptomatic growth, astigmatism, mainly more than 2 diopter, vision problem, and dysplasia. Intraoperative considerations, topical, subconjunctival, and peribulbar anesthesia are given depending on the type of surgery. And these are the grafts which are usually given: bare sclera, conjunctival autograft, or amniotic membrane graft. These are the steps of pterygium surgery. First, we excise the head of the pterygium, then we remove the fibrovascular growth tissue, then we do hemostasis, then we mark the donor area, we harvest it and place it over the excised area with help of fibrin glue, autologous blood, or suture. Postoperative care, a subconjunctival triamcinolone acetonide injection can be given immediately, and topical steroids are also given. This is a picture taken by me. It's a patient with pterygium, and this is his picture after surgery. These are the complications of pterygium, which include hemorrhage, excessive bleeding, scleral thinning, post-op inflammation in conjunctival autograft, endophthalmitis, graft hemorrhage. Then coming to recurrent pterygium, which usually occurs when there is any surgical trauma to the medial rectus muscle has been damaged by recurrent surgery. There occurs reactivation of the inflammatory process present in the primary form. These are the grading system for recurrent surgery 1, 2, 3, depending on the episcleral vessel and fibrovascular tissue encroaching. These are the strategies for decreasing pterygium recurrence, which include mitomycin C, 5-fluorouracil topical sodium fluorescein, anti-VEGF agent, doxycycline, beta radiation, strontium 90. So with this, I conclude my slide. Thank you.
Good morning, class. The topic is recurrent corneal erosion. So let me start with this model of eyeball, where it represents the cornea, the outer 1/6 part of the eyeball, outer covering of the eyeball. The cornea is very vital structure because it is transparent and it contributes about 45 diopter of the total 60 diopter of the power of the eyeball. Cornea is important because it is the layer where the erosions and ulcers are seen. Cornea consists of 6 layers, with epithelium the most outermost coating of the eyeball. So recurrent corneal erosion, it is the chronic relapsing defect of the corneal epithelium, which is caused due to abnormal epithelium adhesion to the underlying basement membrane. Coming to the etiology, trauma is the most common cause of the recurrent corneal erosion. About 1 out of 100 patients of the trauma may end in the corneal erosion. Other causes can be corneal dystrophies or dry eye or meibomian gland dysfunctions. Coming to its pathophysiology. So faulty loose adhesion of the epithelium to the underlying basement membrane, inflammation is the most important cause. Other can be due to defect in the adhesion of the due to defective adhesion complexes and deposits in the epithelium cells. Coming to the clinical features, the most diagnostic feature of the recurrent corneal erosion is that patient complains of mild or severe pain on awakening. So students, can you tell why it is first during awakening mild to severe pain is the diagnostic feature? So let me tell you. Because at night, when we sleep, there is hypotonicity of the tear film, which leads to epithelial edema, and the gap between the epithelial cells is more, and lid is closer to the epithelium. When we wake and suddenly and quickly when we open the eye, then the surface tension between the lid and the epithelium is more than the surface tension between the adjacent epithelial cells, proning more to the epithelial defect, leading to foreign body sensation, photophobia, blurred vision, and lacrimation. Classification of recurrent corneal erosion is in microform erosions and macroform erosions. Microform erosions tend to be milder and shorter in duration, but it occurs in increased frequency. And the macroform erosions, they are commonly seen in the patient's examination. There is conjunctival congestion, and on dyeing with the staining with the fluorescent stain, there is localized area of irregular or loose connective corneal epithelium or corneal defects can be seen. So students, I always say you, don't be in hurry to diagnose recurrent corneal erosion. First, always try to exclude infectious keratitis. Always try to evert the upper lid and to rule out if there is any subtarsal foreign bodies present or not. And never miss to examine both eyes to assess for corneal dystrophy. These are the differential diagnoses of the recurrent corneal erosions. Coming to the management, the primary goal of management is to facilitate the reepithelialization and also to stimulate the adhesion of the epithelium to the underlying basement membrane. This can be done by medical management and also by surgical management. Medically, through the use of lubricant drops, antibiotics, patching and cyclopegia to reduce the pain, bandage, contact lenses.
So that was the end.
Aishwarya, who is Aishwarya? You. Your topic was
CNLD.
congenital. There are some conditions where this is obstruction, congenital obstruction is associated with some syndromic conditions.
Yes, ma'am.
What are those?
Ma'am, in craniofacial abnormalities like cleft lip, cleft palate, there can be bony abnormalities, which there can be absence of the osseous NLD canal itself. So in those cases, we can't go with probing or balloon DCP. So we need to
What is that syndrome known as? What is that condition known as? Where there are these multiple anomalies occur, and which arch is involved in that? Which arch?
Ma'am, Treacher-Collins syndrome.
No, there is a particular syndrome naming that.
Down syndrome.
No.
Regarding
multiple things can occur.
I think there's a tiebreaker. You can't go on multiple questions and giving.
Okay.
So leave it. That's it. I think the 4 judges, you should get together and.
Then primitive IOL के बारे में कौन ये होना? What is positive versus negative dysphotopsia? Positive versus negative dysphotopsia. You know dysphotopsia. What is positive? What is negative? Okay, okay. Sunanda.
Yes.
Rhinosporosis conjunctiva.
Yes.
What are the differential diagnosis or similar type of lesions in the conjunctiva?
Okay. The possible differential diagnosis are pyogenic granuloma, papilloma, squamous cell carcinoma. It can be a hemangioma. That is like foreign body granuloma can be there.
You told in your slides all these conditions.
Yes.
How you differentiate it from pyogenic granuloma?
Pyogenic granuloma. It's a hemorrhagic nodule, ma'am, but its surface is smooth. However, in case of rhinosporidiosis, it's a fleshy vascular structure, and on its surface, it has white or yellowish spots because of mature sporangia.
Okay, thank you. The topic क्या था? Persistent epithelial. How will you measure corneal sensation?
For the corneal sensation, we do the cotton wisp test, where we make a wisp of cotton sterilely. First, we take a cotton bulk and separate it from there.
Corneal sensation is maximum at what point and minimum at what area?
Maximum at the center and minimum at the periphery.
What is the instrument used ideally for corneal sensation measurement? Okay, thank you.